Good afternoon, everyone. My name is Adam Turner. I serve as the Vice President of Scientific Affairs with GT Medical Technologies, and it's my honor to present our next speaker. Dr. Sean Peach is a board-certified radiation oncologist and assistant professor at the ECU Brody School of Medicine in Greenville, North Carolina. He is the director of brachytherapy services at ECU Health. He received his PhD in physiology and MD at the University of Virginia. Dr. Peach is an investigator on the GT Medical Technology START Registry, the newly diagnosed brain mets Rhodes trial, and the newly diagnosed glioblastoma Gestalt trial. Thank you. Dr. Peach.
Thank you. So these are my disclosures. So I just want to talk a little bit about how we got to the point of doing GammaTile upfront for grade 4 gliomas, talk about the phenomenon of rapid early progression and therapeutic ratio in regards to GammaTile, talk about the Gestalt trial and some early findings that we have from it, the Bridges trial, and go over some exemplary clinical cases. So we were early adapters for GammaTile. I think we did the second implant post FDA approval. And so early on, we became a high volume center. We mainly focused on recurrent metastasis and recurrent primary CNS lesions. This was driven in our center because we basically cover a third of a very rural part of eastern North Carolina, and as a result of geographical limitations, socioeconomic limitations, it was hard to get patients back for adjuvant treatment after craniotomy. And then in particular, North Carolina is a state where the burden of the cost of transportation and actual treatment, if a patient is in a SNF or rehab, is to that SNF or rehab. So there's only 3 such places in the region that would take patients. We also use it a lot because we are very aggressive about reirradiation. So we had a lot of patients where any type of external means of radiation, including gamma knife, would just be unsafe. But as time went on, a lot of the initial high volume centers started using GammaTile up front for primary neoplasms. And really the driving factors for this was sort of the same things. There was various barriers to care for these patients, or there wasn't a good solution for a particular patient reason for external beam modalities. So when you look at it, prior to commercialization, the Barrow Neurological Institute, where GammaTile was developed, they had done a series of using GammaTile up front for grade 4 gliomas, and then University of Minnesota, ECU Health, and Piedmont Healthcare, all 3 of us independently early on for various reasons applied GammaTile to, I'll just call these patients, wild type glioblastoma patients. And some was with external beam radiation, some was not. But there was no significant issues post-craniotomy, and we were not seeing toxicity that was anything greater than what you would see with standard of care external beam radiation therapy. The common experience, though, when talking to my colleagues from these other institutions is that some of these patients were having extremely greater than expected progression-free survival and overall survival compared to what we would get with external beam. Why would this be? One thought is that GammaTile might be helping with the phenomenon of rapid early progression. Essentially, this is tumor growth that is observed from the immediate post-surgical imaging to the planning imaging for external beam radiation therapy. This has been reported to happen at a rate of about 46%. Is more common in IDH wild-type patients, and not surprisingly more common if there's a subtotal resection. This meta-analysis from 2022 basically looked at around 700 patients that underwent traditional external beam with craniotomy for glioblastoma. And looking at rapid early progression, it was found to be predictive and prognostic for worse overall survival, as well as worse progression-free survival versus patients that do not have rapid early progression. with the current STUP regimen, rapid early progression is a challenge because we need a 3 to 6 week break between when we do the craniotomy and when we start the external beam radiation and temozolomide, one, so that it doesn't interfere with healing post-craniotomy, and then also to allow for surgical recovery. Unfortunately, this allows both residual microscopic disease that we know is present and, in some cases, macroscopic disease to persist unchecked until we get to that point of radiotherapy and chemotherapy. Using GammaTile up front as the boost prior to EBRT basically allows any residual disease to be treated from day 0 in the most immediate high-risk area of disease. We all know at this point that there's no interference with wound healing post-craniotomy. The question is, is GammaTile addressing rapid early progression, and if it does address rapid early progression, is this going to improve overall survival and progression-free survival in grade 4 gliomas? Another aspect of GammaTile that might be of benefit in these single institution experiences with improved survival with grade 4 gliomas is that theoretically there's a greater therapeutic ratio. Essentially, right at the resection cavity, the disease that's there is getting 90 gray EQD2. And because this is being delivered effectively over 36 days, the hypofractionation LDR aspect of this radiation, the BED is probably actually greater than that. At the same time, the GammaTile boost really decreases integral dose. It decreases the dose to organs at risk, as well as circulating white blood cells. And again, being a LDR delivery, probably is gentler on the OARs as well. This is a patient that we treated that had extensive active scleroderma with involvement of her entire scalp, and presented with a grade 3 glioma, had characteristics of this disease that we definitely should treat her with radiation. There was no way we're going to do external beam radiation. We went for craniotomy with GammaTile placement, and you can see here the GammaTile dose that the patient received is in green. Red is if we had done external beam, and the scar and scalp get significantly less dose, and then the entire brain, the integral dose, is significantly reduced. And so when we look at glioblastoma overall, it does seem every 10 to 12 years that we have a major milestone and advancement in treatment that improves overall survival. And so when you look at the immediate dose of radiation after surgery, the hyperfractionation effect of an LDR source, this resulting in greater BAD, and the very sharp dose fall off that is protective to the OARs, it's possible that GammaTile delivery might be the next milestone to improve performance as far as survival and disease control for glioblastoma. So given the single institution results early on that we were seeing, GT Medical decided to do the Gestalt trial. This is a single-arm feasibility trial, basically looking at how feasible is it to deliver GammaTile, and then follow this with external beam radiation, and having that external beam radiation start in a timely fashion. AIM-2 was looking at safety, and then we had traditional outcome performance data. The design is basically to enroll patients that have a MRI imaging that is consistent with a high-grade glioma. They undergo GammaTile delivery with craniotomy, and then they start 4 weeks later with external beam radiation that is, I'll show you, matched to the fall off of the GammaTile dose. Dr. Stupp helped in the design of this trial, and so rather than doing 23 days of radiation, it was reduced to 4 weeks. This slight hypofractionation probably has a benefit radiobiologically, and also it's more convenient in that for the patient in that you're fitting everything in 4 weeks. After a 4-week break, then we go on to adjuvant temozolomide, and tumor treatment fields were up to the discretion of the institution and patient. So how the how the external beam dose was designed was first the GammaTile dose is converted to EQD2, and then the adjuvant external beam radiation dose is basically feathered inward to match the 46 gray isodose line of the GammaTile dose delivery. That basically recreates the high dose 60 gray volume and the moderate dose 45 to 46 gray volume of the STUP regimen. For evaluating the plan, basically we want the composite dose of the resection cavity, and if there was any residual disease, to receive 60 gray with margin, and then the area outside of that where there was flare signal to get a homogeneous dose of 45 to 46 gray with margin. And what you get is these C-shaped and donut-shaped volumes. And I'll show you with one of the clinical cases in more detail what we are able to achieve. So we did reach accrual with over 60 patients in August. And while it's still early to show the final results as far as safety and efficacy, we did do a preliminary, there was a preliminary presentation of a subgroup of these patients looking at rapid early progression. And as you can see here, that we saw a rate of 20%, which is more than basically less than 50% of what has been observed in the literature. So with this success, oh, and sorry, there also was cases of what's called rapid early response. So this is a patient that, in the Gestalt trial that had a partial resection. Understandable, this is parafalcine disease. And when you look at the 2-week planning MRI, the disease is shrinking in volume. So we're getting, we're not only, we have evidence of with the decrease in rapid early progression of treating the microscopic disease, we're also having evidence in this trial of treating the macroscopic disease. So with the success of this, the basically next trial that GT Medical is going to release, and I'm proud to officially announce, is the Bridges trial. I have to say that the company's very creative and clever with their names. And so this is going to be a phase 3 trial that is going to start enrollment and start activation in winter of this year. And it's for patients with radiographically diagnosed glioblastoma. Very similar protocol to Gestalt with some changes. And basically, it's a randomization of standard of care, the firmly established STUP regimen versus GammaTile boost with EBRT. The only caveat being that tumor treatment fields, again, will be completely up to the discretion of the institution and patient. The primary endpoint is going to be overall survival. In addition, secondary endpoints is going to be looking at progression-free survival, quality of life, various forms of toxicities, and safety. And there's going to be a maximum number of patients of 766 with up to 80 centers involved in recruitment. There will be a randomization ratio of 1 to 2 between the experimental arm and the Gestalt arm. The other thing that I want to mention is that there's been a lot of work we've done with recurrent glioblastomas as far as treating with GammaTile, and that this is a recent released ASTRO guidelines where for recurrent glioblastomas, there is now a moderate quality of evidence, including brachytherapy as a treatment modality, and that's a change from before. So now I'd just like to go over 2 quick cases. So this first one is kind of what got things going for us with the upfront treatment of glioblastoma. This is early on. I mean, we weren't even into the double digits yet of GammaTile cases. And so 40-year-old female presented with seizures. She has a significant history of schizophrenia, drug abuse, is homeless most of the time, and basically has this imaging where there's not much on the T1 post-contrast image, but you're seeing the signal change on T2, so it's thought to be probably a low-grade glioma. Well, she comes back for pre-op imaging one more time to get a better MRI 3 weeks later, and this is what it looks like. Classic appearance of a glioblastoma, and I mean, in my small experience as a radiation oncologist, I'd say I've never seen glioblastoma progress this fast clinically. But the issue that we kept having is we kept canceling surgical procedures. We couldn't get her to surgery. She lived an hour and a half away, but her parents lived in Greenville. And so they were trying to keep her at her parents' house, but if she was left alone, she would be seeking. There was a lot of criminal incidents with acquaintances and whatnot. The parents just couldn't keep her there safe. And so Dr. Stuart Lee, who's my right-hand man, he's the main driver from the neurosurgery side of our GammaTile program. He came up to me and was like, hey, can we just throw GammaTiles in her? And, being freshly out of residency, I was like, this is not standard of, it's radiation, but I feel kind of uncomfortable doing this. But, he said, I don't think we can get her anything else. And if we let this go, she's going to be dead in like weeks. This is really bad disease. And I was like, all right, let's do this. If the patient is up to it and the parents are up to it, let's go ahead. So, we had I was very honest with them that I was like, this is something that is, not truly experimental, but I just don't know how this is going to end up, but it's better than not doing anything. So went ahead and did it. And it was a fairly large lesion, 8.5 tiles, 34 seeds. Again, the goal here is to get 60 grays to 5 millimeters. One of our now retired physicists is very OCD, so he would like to color code the seed sources by tile. So I like these images because they do show, this is another way of displaying it, how well the tiles keep the dose, the dose distribution between the seeds very even, and that's why you get this very robust system. Is the dose clouds are very reproducible. So 4 weeks passed. I see her in follow-up, and it's like I'm talking to a different person. She's doing great. She's been with her parents the entire time. She's had no significant issues whatsoever as far as relapsing. And so I'm like, well, geez, do you think maybe we could add some radiation at external beam? And I've been telling them basically, we know that there's microscopic disease that's beyond where the GammaTile went. And so it's only a matter of time that's going to progress. We should probably try to do this. And again, I told them, like, this is new. We're going to have to figure out how we do this. And they were up for it. It was great working with Dr. Brockman, working with Dr. Turner. Dr. Garcia wasn't there yet, but he's also great to work with. Were extremely helpful. Essentially, we had a prior patient where we were doing beam matching because we knew that there was going to be a subtotal resection, so we came back with RT to the tail that we weren't going to hit. And so Adam and I went back and forth, and Adam was able to figure out how to get this GammaTile dose to EQD2. So that was we already had that problem figured out. When we did that, we used this technique where people that you can basically combine IMRT external beam plans if you have to have two isocenters for craniospinal, like for an adult, to feather the doses so they match. And it consists of making a bunch of rings and whatnot, very labor intensive. But what Adam was able to figure out with one of our dosimetrists is that we could use that EQD2 dose as a target objective in the Eclipse planning system, and it automatically made this just feathered dose distribution that overlapped with that dose. And so basically what we ended up making is we did the flare expansions based on anatomy. We feathered the dose to the 46 gray line. The central area that is beyond 46 gray GammaTile EQD2, we just made that Alara, and we were able to make this volume using 5 arcs, 2 that were non-coplanar, and this is the resulting volume. So we get this nice donut, then you add the GammaTile EQD2 dose on top, and you recreate the traditional stuff volumes. So we're going through the radiation, she's doing fine. I'm thinking maybe we jumped the gun a little bit. She could have handled the 6 weeks of radiation, but it turns out she missed her last fraction, and then she wasn't seen for 3 months. Like she got off the wagon, and eventually her parents hunted her down. They found her. They got her into this wonderful institution for those who are schizophrenic and also have substance abuse issues. Really turned things around for her, and then this is darn it. Okay, just sorry that everything got layered up. Basically, what you're looking at here, although it's covered over, is at 26 months, absolutely no evidence of enhancing disease. And you can't see the flare, but on the flare, there literally is the littlest touch of a radiation effect. What Dr. Kotek was talking about before, we see less radionecrosis from GammaTile than we see with external beam means with external beam means. Now, unfortunately, when she was about 3 years out, she recurred and she went very fast. But the thing that was just so great for this patient was she had a young son that she was alienated from all the other stuff that she was doing. She had parents she was alienated from. She literally had 2 solid years of really normal life with her family and her kid. That no way that would have happened without GammaTile. And then the thing that's interesting, I got a chance to talk to Dr. Stupp this year at the Radium Society meeting. And then I've talked to other colleagues about this. There is this common pattern of failure for these patients with glioblastoma that have phenomenal progression-free survival and ultimately overall survival. They seem to just go through a very explosive progression of disease. And this basically highlights that, we still need a lot of work on systemic treatments, but there's a lot of promise with that on the horizon. And similar to pancreatic cancer, the better that we get with our systemic agents, the more important local control is going to be. And I don't think that there's anything that can do the local control better than GammaTile. And then, let's see, I'll go through this last case pretty quickly. This one was interesting because some of the neurosurgeons who have been using GammaTile for a while, especially in the pre-FDA clearance time period, there was some elderly patients where they did GammaTile therapy and they did it alone because they just didn't think that the patient would be able to handle external beam. At least they were doing something, and some of these patients did well, had disease control for a very long time. And so there had been some discussions of, why are we complicating things with the external beam radiation? Do we really need to add external beam radiation? We're just, because we have these systemic different other add-ons we can do if we can knock out the main disease, maybe we don't have to complicate things. And we ended up having a patient that, at least in this case, showed the importance of the external beam part. So essentially this guy, very healthy, 53-year-old, typical presentation, and has this left temporal glioblastoma. He was totally good with getting at GammaTile. We tried to get him on Gestalt, but he wanted to be off trial. But when I talked to him, he was very persistently talking about temozolomide and the toxicity of chemotherapy. And I spent a good hour and a half talking to him and basically telling him, like, this is very mild chemotherapy. It's very helpful. You look like you have MGMT mutated disease, just radiographically. So went on, and ironically, it's 8.5 tiles and 35 seeds. And went to see him 4 weeks afterwards, and did not want to do external beam, did not want to do chemotherapy, and he went out of the country for some experimental treatments. And so fortunately, he did stay in touch with the neurosurgeons, and so 1 month he looked pretty good, just surgery response. That could be a little inflammation from the radiation as well. But when we get to 3 months, the anterior fossa where the tumor was looks fine. But we are starting to get more edema just above there. At 6 months, you see this thickening enhancement, but this is a pattern that we've noticed for the base of skull tumors, that there is this, I think it's a reactive fibrosis that happens from the GammaTile. So not worried about that, but we are clearly worried about that. So, but he's not symptomatic from this at all. So, but when you look at it, and Dr. Kotek talked about this, the dose fall off is fast. So it goes from 60 to 45. This is EQD2 converted very fast. And so this is like, it turned out beautifully. I wish I could show this in 3 dimensions. Literally, what we would have used as the flare signal to do the external beam volumes is exactly where the enhancing disease was. And when you add what was delivered, there's not, this is literally just above where the GammaTile delivered dose. So this patient, it was very likely would not be progressing had he gone that external beam radiation. But he still was trying some other things. Unfortunately, 8 months, he developed another seizure. The imaging was kind of wonky. T2, like it was one of those things where like it could be pseudoprogression, but we did get a contrast clearance scan, and I can't tell you what that means, but per our radiologist, that green thing in the middle was extremely suspicious. So what we ended up doing, and this shows the robustness of GammaTile, I just pretended like he never had GammaTile and made plans with STOPA regimens based off of what we were seeing at that time. And the only thing that I did different was that when we did the planning, we brought in the EQD2 dose from the GammaTile, so we saw what the total doses were going to the OARs, and then limited the composite dose so that it was really the brainstem in this case was the really hard thing to work around. Limited that dose so that we would lose coverage in order to stay safe. And so you can see it here, especially in the bottom corner here, that some of the low dose and high dose CTV, because of the brainstem there was no way for us to cover it, but we covered most of it pretty well. We got 90% of the CTVs covered as far as the high dose goes. And then when you look at the composite dose, what I found fascinating with this is the 90 gray plus area was very large, but this patient had no toxicity at all from this up to 6 months out. So this is him 6 months post-op. I know that looks scary, but again, this attests to using more secondary MRI imaging. This was definitely pseudoprogression at that point. Now, unfortunately, the patient now is about 2 years out. He is in hospice, and basically what ended up happening is those areas around the brainstem where we couldn't throw that much dose, he ended up progressing there. But again, clear example that what we know histologically, that those microscopic cells are there, and that flare signal, it has to be covered. And so, these are my conclusions, but I think I'll save some time for questions.
So you presented some what we would probably consider, the more difficult side of the spectrum cases to treat with GammaTile. Would it be possible for kind of just take us through at a very high level your kind of standard workflow for treating GammaTile patients, basically roles and responsibilities from the time of case selection through post-operative evaluation?
Sure. Yeah, so we kind of, when we started out, we sort of had one sort of flow that we would work through. Early on, when the company was just making tiles in one center, we were trying to get 5 business days heads up to order the tiles. And so really we were looking at a lot of recurrent lesions where we could review them at our, we have a CNS tumor board, but we have a Gamma Knife one where like the real difficult and pertinent stuff happens. And so, basically evaluate patients at that tumor board. I would sit there and draw out what I would expect the surgical cavity to be. If it was something that wasn't straightforward as far as what the surgical approach is, I would definitely either curbside the neurosurgeon or send them some videos of what I was thinking was going to be the roof. Once that was confirmed, which really that doesn't take hardly any time, our physicist would then do the basically hand calc the surface area, and this is before there was the lookup tables. And once you become proficient at that, that's again just a couple of minutes. And then for us, we like to be involved in the cases. So most of the oncologic surgeons, they're doing cases on the day when I'm supervising the machine. So it's very easy for me to leave, go to the OR, deliver the tiles, help give my 2 cents, and then come back. Now we have a lot of the neurosurgeons who are not necessarily on the oncology side, but they are coming up with METs and stuff when they're on call involved. So one, we're using the lookup tables a lot more, especially because this is the thing. The 3 of our last 4 cases, we ordered tiles the day before the surgery, which could not imagine that years ago. It has not been a problem. So with that, we sort of have this, there's the traditional, let's think about these more difficult, complex cases, but then the ones that are really chip shots, they basically call me, I do the work, get that going. We get another neurosurgeon and another radiation oncologist just to be a second check for the overall plan, order the tiles, and get going.
What are your thoughts on the relative importance or lack thereof of concurrent temozolomide with the tiles? Obviously, you have to wait for some amount of surgical healing before you can start temozolomide, but at some point you could overlap it with the natural life of the tile. What do you think the value is in using that or not using that?
So, this would be all conjecture on my part, but we know the benefit of chemotherapeutic sensitization when we're doing definitive radiation, and in a way, even though this is adjuvant, that immediate surgical cavity has so much microscopic disease that's so aggressive that we need definitive doses, and so especially those that are methylated. I think there's a significant benefit of having that on board while you're doing the radiation, and I guess it would be a if we could get evidence to sort of see, is there a window in which, because temozolomide from a tissue aspect isn't too rough on the system. If we could sit there and tease out, like, is there a safe window, maybe it's 1 week, 2 week after craniotomy, that we can start adding on the temozolomide. If we could do that, I would imagine for the MT methylated, that would probably improve the control. And then also, the more distant disease would also be addressed at an earlier time point. It would be similar to hormone therapy when I'm treating high-risk prostate cancer patients that, I'll get you on the hormone therapy. Worst case scenario, things are steady. And so if we could get the temozolomide early, I could see that being a steadying agent till we get to that point where we can do the external beam.
Thank you.